Next, we have Dr. Damiano Rondelli with us from the University of Illinois at Chicago, who will be speaking about Philadelphia negative myeloproliferative disorders. Dr. Rondelli, welcome.
Thank you. First of all, thank you for being here. And although I'm sure that you will like my slides, I also would like you to keep an eye on this slide here, because the Binaytara Foundation has been a fantastic opportunity for some of us to work not only in the United States but also across the ocean and develop some beautiful work thanks to Binay in other countries. And this is really inspiring for me, and I'd like all of you to consider and to go through the brochure you have and see what the projects are, and maybe help us develop even further our work in Nepal and other countries. The other thing is actually, I don't have a slide for my disclosure. I want to say that I've participated in advisory boards for Insight and Alexion as companies, and have a speaker bureau of Sanofi as my disclosures. To talk about changing scenarios in the treatment of MPNs, I think that it's important to talk about a little bit about the prognostic factors that have been changing over the last few years, and the diagnostics and prognostics will probably take us even further in the future with the more targeted therapy in these diseases. How do I do this? Yeah. So we are still stuck with the WHO classification for these diseases, the myeloid disorders, and we're going to focus on the Polycythemia Vera, ET, and myelofibrosis. But what you see here in this slide is actually that the names are the same, but what is changing is the blue lines that you can read, but are the increasing information on molecular discoveries and mutation associated with these diseases. And this actually will translate into different prognoses, as you'll see in a few minutes, as well as probably and hopefully in new treatments. And this actually applies to any cancer, as you've heard yesterday, and you'll probably hear later today. And some actually of these mutations are also shared with some solid tumors. And that's why the classic diagnostic criteria for these diseases are the same for polycythemia vera, for essential thrombocythemia, and myelofibrosis. But what is actually different is now that the diagnostic value of finding specific mutation has a really relevant diagnostic meaning for these patients. And of course, this all started 10 years ago when different groups in the world, but I think mostly the French group in Paris reported the JAK2 mutation, JAK2 V617F mutation, as being present in the vast majority of polycythemia vera patients. At the time, it was thought actually this mutation could have been the driver of the disease, and then if we blocked the JAK2 mutation, we probably would have accomplished what we did in CML before, stopping the disease. And that started a lot of work from drug companies, and the story has actually changed quite a bit. Other mutations have been discovered, have been the MYPL mutation for myelofibrosis and essential thrombocythemia, and the exon 12 mutation in the JAK2 region in polycythemia vera. But, and the way it works, this mutation, as you probably already know, is actually many receptors that cells have depend on the JAK2 STAT signaling inside the cell. And when the mutation is present, there's no the cells does not need a cytokine to trigger the receptor, but it will start signaling inside the cells and to the I don't know what I did, and to the nucleus constantly without stopping. And that's why a red cell progenitor without erythropoietin can still make a lot of red cells, because this signaling doesn't stop. The new kid in the block is the CALR mutation that was actually reported a couple of years ago, and from European groups, and showing actually that many patients who are JAK2 negative with myelofibrosis or essential thrombocythemia have actually this other mutation, which is CALR mutation. So if we put together this mutation we know, the landscape of MPNs, we see actually that most of the patients that we will see with these diseases do have indeed a mutation that we can actually identify. In polycythemia vera will be mostly the JAK2 mutation. In ET and myelofibrosis will be, again, JAK2, but also calreticulin and MEPL mutations. So only a very small group of patients will be what we call the triple negative patients that also we have in this category, and then we'll talk about them before, in a minute. That is not it. There are other mutations actually have been described in these diseases, epigenetic mutations that are not only present, but actually have a prognostic value. IDH1 and 2, TET2, these are actually, as you just heard, often found also in AML patients or in other myeloid diseases. I'll talk about in a few minutes about AXL1 because it actually has a prognostic value together with JAK2. So historically, we have always, whenever you have a patient with a ET or polycythemia vera, the question is, one, to treat the patient, and what are the factors that you want to consider? It's very well accepted and known, and these have been criteria and algorithms and scoring system have been put together, analyzing many factors, that the age, the leukocyte number, and the prior vascular events, thrombotic events or hemorrhagic events, are really relevant whenever you decide to treat a patient with hydroxyurea or not treat a patient. So it's not 1 million platelets that will make you treat an essential thrombocythemia patients, but will be the risk factors. And if a patient is 45 years old and has no history of DVTs in the past or other thrombotic events, 1 million platelets does not really mean anything, and you don't want to treat the patient. The finding actually have been, in polycythemia vera, we always thought actually the hematocrit of 45 was the real number that we had to look at. But until actually a couple of years ago, we did not have actually the proof of that. And instead, it was the European group led by the Italian colleagues did an analysis and showed actually 45, hematocrit 45 is associated with a risk of cardiovascular deaths and vein thrombosis. And that's why we want to keep in polycythemia vera patients this hematocrit below that number. And you will see patients actually would need a little bit less than that as well. But that's another milestone. In myelofibrosis instead, the prognosis has changed when a few years ago, the prognostic factors, the international group put together a bunch of prognostic values to analyze which were relevant. And they came up with 5 prognostic factors that have been the age, the symptoms, anemia, white cell count, and blast. And this actually was analysis was based on patients' diagnosis. And so what it was called the IPSS score was actually defined as survival that was very different from those who had 0, 1, 2, or 3 or more of these factors. This actually prognostic system has been implemented over the years to add other factors such as platelets, unfavorable cytogenetics, and transfusion. And the anemia actually is the most important value. And it's been also demonstrated that this scoring system applies to at any time of the patient history, not only a diagnosis, but whenever you see a patient that has been on treatment for a while or has disease for a while and has these factors present, these are still valuable in defining the prognosis. And you see here the difference in survival goes from over 10 years to less than 2 years, 1.5 years. So those actually are criteria that we are now following whenever we have to decide on treatment for myelofibrosis, especially for transplant. Now, these mutations that we described are not only very useful in the diagnostic setting, but also have been shown to have a prognostic value as well. Calreticulin has been associated, for example, in essential thrombocythemia with a reduced risk of thrombosis. And that's an important element to consider when you want to treat a patient. Also, in myelofibrosis, calreticulin protects patients, so it's a favorable prognostic factors for patients with compared to patients with a JAK2 mutation or a MYELOPROLIFerative mutation. This was actually a paper that Teferi published from Mayo Clinic last year to show a survival analysis of patients with MPNs, not based on DIP score, on IPS score, but only on mutation status. And you see here that the calreticulin mutated essential thrombocythemia has a better survival than the non-calreticulin mutated patients, and in myelofibrosis as well. These are the mutated patients versus the JAK2 mutated patients. You see a big difference in this two survival. And this actually was another paper that was published by Teferi at Mayo Clinic showing the triple negative, which we have known in other cancers, but also in myelofibrosis, the triple negative patients do very poorly, and do poorly compared to the non-mutated patients as well as to the mutated patients. So this is a small group of patients, as you saw at the beginning, but that deserves particular attention, especially when in myelofibrosis, where we're going to talk about bone marrow transplant. Another very important element actually has been to show that the ASXL1 mutation has a poor adverse significance in these patients. So the question that actually we're now asking in this patient, I just saw a patient last week where myelofibrosis DIP score intermediate 1, so patients with 10 of hemoglobin, and he would not be a candidate for a transplant, but he turned to be XL1 positive, and he traveled all over the world to the major centers to have a second opinion, including the MD Anderson and Mayo Clinic, and everybody told him that he needed a transplant. So those are things that are not yet demonstrated formally, but it's become like more and more important whenever we see patients that are in a transplant eligible, in a transplant age. AXL1 mutation actually is important. So how do you treat the patients? Of course, hydroxyurea, that's a slide that I show all the time, especially to the residents and to the fellows. You want to start patients on hydrea if they are older than 60 and have a history of thrombosis in essential thrombocythemia. Even the platelets are not more than 600 or 500,000. These are prognostic factors that are still valuable. There's been a lot of discussion on anagrelide, the very old drug that people have used on and off. Young physicians don't even know it, but old physicians love it. And so there are patients that have been on it for 10 years and more. But there was actually a controversial finding 10 years ago about anagrelide in the PT1 trial that would have associated this treatment with the higher risk of thrombosis. A few years ago, there was another study actually instead that was showed that there was no really difference between hydroxyurea and anagrelide in these patients. So patients with essential thrombocythemia that cannot tolerate hydroxyurea or for different reasons, they can indeed still be treated with anagrelide and successfully. Of course, that's another resident slide. You want to give aspirin to any polycythemia vera patient, no matter what, no matter how, unless they are on anticoagulation treatment already. That was actually a major discovery that was published probably about 10 years ago or more, and it's still a very valuable treatment. But the big new thing in the treatment of these diseases has been the JAK2 mutation story. And the question is whether or not targeting the JAK-STAT pathway may improve the disease. So first of all, as you know, JAK2 mutation is not the Philadelphia chromosome is not the BCR-ABL mutation for CML. But many people have been very involved and intrigued by the initial finding that in myelofibrosis patients, the treatment with JAK2, and there was a study published by Serge Verstovzak at MD Anderson, reduced in a significant way and in a very rapid way the spleen size, the size of the spleen, as well as the symptoms of patients with myelofibrosis by reducing the inflammatory cytokine pattern in these patients. So this is very important because in these diseases, and this is actually a very important work that Ruben Mesa actually has developed over the last couple of years, these patients, the burden of symptoms in patients with not only myelofibrosis but also with polycythemia vera and essential thrombocythemia is huge. So you see here actually that a lot of these patients do have symptoms that affect their quality of life in a significant way. That could be the pain, or it could be fatigue, or itching, or fever, weight loss. These are affect not only all these MPNs are significantly affected by this thing. So the premise actually that the JAK2 inhibitor may reduce the symptoms has been very interesting and important in addressing these things in not only myelofibrosis but also in ET and PV. And there are, you see here, there have been trials being run on ET and PV with with different type of JAK inhibitors. But the one actually has been already done has been the use of Ruxolitinib in PV and ET, and this actually was data presented initially 5 years ago at ASH, showing that the symptoms and the spleen size also in polycythemia vera patients could have been improved very quickly as well. And very recently, Alessandro Vannucchi published in the New England Journal of Medicine the study of the response trial with Ruxolitinib in PV. We're showing that it had an effect on the symptoms, on the spleen size, on the hematocrit control, so it could improve the hematocrit, and the response to Ruxolitinib actually seems to be stable over the time. A very intriguing drug to me, and because I see these patients actually, is pegylated interferon. You know, interferon is a drug that many people have hated in the past for CML patients, before Gleevec, and for other patients had a lot of toxicity and patients didn't really like it. The pegylated form of interferon has been introduced in polycythemia vera essential thrombocythemia. With weekly injection, subcutaneous is much more tolerated by the patient, is not as bad as they thought or it was, and I see that my patient at least tolerate quite well. The intriguing thing, the results of these studies, actually they were published by Quintus Cardama, has been actually, they achieve a very high response rate in PV and ET patients. And these are patients that most of the times in the studies had been already treated with something else. They had been treated with hydroxyurea most of the times. And still you can induce a complete hematologic response controlling the platelet numbers or the hematocrit in over 75% of the patients. Even more than that, with the JAK2 mutation status, a number of patients would achieve a complete molecular remission or a partial molecular remission. Now, we don't really know what that means, if that means longer survival or less risk factors, but I think it's always nice to see a complete molecular remission. Although I don't think we know exactly well the mechanism for the pegylated interferon to do that, there are many hypotheses, but it's a very striking result. And in this study, actually, it was shown that the patients who likely will not achieve a complete molecular remissions are those who actually acquire other mutations on top of the JAK2 mutations, like the TET2 or IDH1 or AXL1. Now, the question is, though, is if you have a new patient, would you start him on hydroxyurea or pegylated interferon? And of course, this is a question that can be answered only through a clinical trial, and that's actually what the MPD, the Myeloproliferative Disorder Research Consortium, actually has been addressing. Now, this trial is still open, and there are patients being enrolled all over the world to patients with high-risk polycythemia or essential thrombocythemia who had been diagnosed within 3 months and are started in a random trial between the two drugs. And we'll see the results of that study. For myelofibrosis patients, before the Jakafi or the Ruxolitinib came on board, the many options that are listed here were kind of not very effective, none of them. Androgen, hydroxyurea, 2-CDA, lenalidomide. there have been trials and attempts to improve the outcome of myelofibrosis patients, but none of these actually have been very successful, have toxicity, and the big change was with the Ruxolitinib and the study. There were the COMFORT-1 study and then the COMFORT-2 studies were done, and showing that when it was randomized against the best available treatment or anything that the doctor would give these patients, it was shown actually Ruxolitinib could improve the symptoms, the splenomegaly, and also a further analysis of the COMFORT-2 study suggested a potential survival benefit, and this is probably related to the patients who are not on a JAK inhibitor. Of course, have a much worse quality of life, had much worse risk of other events. They become cachectic. They have symptoms and fever and infections. So there is an advantage. What Ruxolitinib doesn't do, though, it doesn't reverse the myelofibrosis. It doesn't really improve the fibrotic status of the bone marrow, and so it's not really a driver of the disease, but actually has a big impact. Now, what we know, though, and this is important for the next slide I'm going to show, Ruxolitinib is a drug that is not specific for the JAK2 mutation, and not even for the JAK2. It blocks actually JAK1 and JAK2 and JAK3, and so it has a broader area of which can be in some way negative, because you would probably may expect more side effects from that, but also I will speculate on something that might also be less toxic in another way. So Versazek also demonstrated actually that people who actually achieve a better response on the spleen size will eventually live longer. And that was a study published in Blood a few years ago. Very recently, actually a few weeks ago, and that's what I was talking about, there was a study reported on JAMA Oncology where people try another JAK2 inhibitor, and this is JAK2 specific. So it blocked only the JAK2 gene, and is called this drug fedratinib. And this study was done on a very large number of patients, and there were 2 doses tested, the 400 versus 500, or placebo, a randomized study. And the aim was a spleen response, basically similar to the Ruxolitinib. And what it was shown actually was indeed this drug, the JAK inhibitor, had a good response, on spleen size and symptoms. And the problem was actually that there was a neurotoxicity that was shown in 4 patients with encephalopathy that actually was fatal, and the drug was stopped. The clinical trial was, the clinical development was stopped. So the assumption actually in this paper was actually that JAK2 inhibitors, if they're more specific to the JAK2, they're likely to have better chance to cross the brain barrier. And so they can cause more toxicity to the brain. And this actually happened also to another initial JAK2 inhibitor before even the Ruxolitinib was approved, that was stopped because of neuropathy, but also damage to the brain. So this is a concern for the new drugs that have been developed. What are the possible neurotoxicity for these drugs? And you see here there are a bunch of actually other JAK inhibitors that are being tested. Some of them are close to phase 3 studies, and we'll see probably in the next few years others. Very briefly, since we've heard that mTOR inhibitor being tested in other cancers and be possibly beneficial, it was also tested in myelofibrosis a few years ago in Italy by Alessandro Vannucchi, and it was shown actually, even if it's a completely different mechanism of action, it's not a JAK2 inhibitor, it doesn't stop STAT, but still the mTOR signaling is important, and they could achieve the similar results as the JAK inhibitors by blocking the mTOR signaling. And there was a phase 1-2 studies with the RAD-001, the everolimus drug. Now, the only option to cure these patients, especially myelofibrosis, remains bone marrow transplant. And we and others actually demonstrated already many years ago that actually bone marrow transplant can really reverse the myelofibrosis completely in these patients, which is a very interesting thing that I have not yet completely understood. but obviously the fibrosis depends on the fibroblast, and it's a secondary effect to the cancer. It's not really a cancer feature, but is but the good thing, actually, we can reverse it and patient can be cured. We also know that JAK2 mutation is a very valid marker and MRD marker after transplants. And we can actually, and Kroger in Germany published many years ago that DLI could have been given to patients who remained JAK2 positive after transplant. There's here a study that was published again by the Germans showing actually that people who remain positive have a high risk of relapse after transplant. So there is a bunch of questions still there about transplant myelofibrosis, who should be transplanted, what condition regimen, what donor, splenomegaly, is it a big issue? JAK2 mutation, does it make it worse or better? Now also reticulin mutation, and is it good to use JAK inhibitors? Those are the questions that are really right now being tested in trials, and I think the next few years we have all these questions answered, and we already know some of it. This actually was a slide that I borrowed from Nick Kroger, showing who you would transplant with myelofibrosis, and we all agree that actually intermediate 2 patients and high-risk patients actually have a prognosis of less than 4 years or 2 years, depending on the risk, and those are the people that, if are young enough, should go to transplant. The big question is on intermediate 1 patients, especially now because we have new mutations that, as I mentioned before, but also because, as you'll see in a second, the best data in transplant have been seen in patients with intermediate 1 who actually were transplanted because of different scoring system. So the question is, if intermediate 1 patient has a long survival without transplant, but when do you decide that it's time to change to go to transplant? The patient can have a advanced in his disease, the anemia can get worse, still being intermediate 1, but you see a different path in the disease, and those are the patients that, to me, should be sent to transplant before they get to a stage where the transplant has less chances. There have been many studies in the past, I'll do very quickly, about myeloablative versus non-reduced intensity transplant. I think initial studies were done with the myeloablative when that was the only option, and there was found actually patients above 45 years of age had a very high transplant-related mortality. So that's people who were not really very intrigued or happy to do transplant, especially most of the patients with myelofibrosis would be over 50 years of age or even over 60. The introduction of reduced intensity regimen changed quite a bit the story, and these are 2 retrospective studies that were published over 10 years ago, one from the Seattle group and one from our consortium study, where we showed actually that reduced intensity had much better results in a retrospective group of patients. Also, we showed that the splenomegaly that can be sometimes very extensive, over 25, 30 centimeters, improves over the time with the transplant. So the question is, does a patient need to be splenectomized prior to transplant or not? Unless it's symptomatic, there are pros and cons, but right now we don't recommend the splenectomy on every patient. And it goes along with the improvement of the myelofibrosis. The first prospective study that has been done in myelofibrosis for transplant was done within the EBMT group, the European bone marrow transplant group, mostly in Germany, where they showed in 100 patients that a regimen with a low-dose busulfan, fludarabine, and ATG achieved actually very good results in a prospective study, especially if patients were younger than 55, if they had an HLA matched donor, and if their score was actually, of course, a lower risk would do better. The prognostic factors have been developed in bone marrow transplant for myelofibrosis. These are very important things because it would tell us what are the risks that we want to take when we send a patient to transplant. And this is not yet completely clear and agreed upon, but the German people define the JAK2 wild type, so not having a JAK2 mutation, being older and having symptoms gives a higher risk of death after transplant. An Italian study showed actually that having a large spleen, having a lot of transfusion, and having any donor outside the HLA matched sibling would have a high risk. So we did a study, the first study that was done prospectively in the United States, on transplant myelofibrosis was done within the consortium. We enrolled 66 patients. And we looked at all these factors as well. So the first finding was actually that patients who had the matched sibling in a prospective study did very well, had over 70% survival, and probably cured. And as opposed to the unrelated transplant that showed this was a regimen, it was a transplant done with fludarabine, melphalan, and ATG for unrelated donors. We saw a lot of rejection and graft failure in the unrelated arm. And this was not dependent on the HLA typing, and was not dependent on the JAK2 mutation. So in our study, to have or not to have a JAK2 mutation did not really define a different prognosis for these patients. And even the age, we didn't find any difference in patients above and below 57 years of age within the sibling or the unrelated group. Recent papers showed that calreticulin is actually also good in the transplant setting. Patients with the calreticulin mutated do better than that's a small study. There's a letter that was published in Leukemia last year. Again, the triple negative patients do worse even in the transplant setting, and that's interesting. Not really because of relapse, which is what you would expect, but mostly because of transplant-related mortality. So these are patients with more affected organ function. So the question remains, will JAK2 inhibitors, you shut down the cytokines, you improve the performance status, you eliminate all the symptoms. It makes sense that it would benefit the transplant. That's what we are really right now thinking. There's been a first report last year about 14 patients who had a transplant with a prior treatment with a JAK inhibitor, with the Ruxolitinib, and it's hard to draw any conclusion. Some of them relapsed, some of them had GVC, but so again, the only way to know if this is actually really meaningful or is helpful is through a clinical trial. And actually the MPD consortium is also running another study with which is right now open to do transplant using the fludarabine busulfan ATG regimen from Europe, with 3 months of treatment with ruxolitinib before the transplant, tapered off until 2 days before the transplant, the conditioning regimen starts. So this will be the answer to this question, that hopefully next time when we talk, we'll have this information. I think this is my last question, and I want to thank you with a reminder again to Nepal and to the Binaytara Foundation. Thank you.